We're live now, thanks, Chair.
Thank you for that. Good afternoon, everybody, and welcome to the virtual meeting of the Health Scrutiny Panel. The meeting is being live streamed via the Council YouTube channel, and whilst members of the public can view the meeting, they will not be able to actively participate or comment on proceedings. As the meeting is being live streamed, it would remind all participants that their conduct should reflect this. Normal rules of procedure apply with any questions or comments directed through the chair. I'm chairing this meeting today and I'm vice chair and my name's Dorothy Davison. So can we go on to agenda item number 1, apologies for absence, Scott, please.
Yes, Chair, we have apologies from Councillor Bell and Councillors McIntyre.
Thank you very much.
And Councillor Starry. Thank you.
Thank you. Agenda item number 2, which is the declaration of interest. Have we got any declarations of interest for this afternoon? I presume that's no, thank you. Agenda item number 3, minutes of the previous meeting held on the 8th of February. Can we agree these minutes? You, Ron, yes? Can I have a seconder, please?
Agree, Chair.
Thank you. This afternoon, we further discussion on health equalities under the health service perspective. This afternoon, we're going to have presentations from, a first presentation is from Katie MacLeod, Head of Commissioning and Strategy for the Tees Valley CCG. Are you able to start now? Thank you. I presume everybody's had the Tees Valley overview and I've had a chance to read it, and this will be the presentation on health equalities briefing. Thank you.
Many thanks, Chair. Thanks for having me today. Nice to see you all. So as you shared, Chair, I'm Katie MacLeod. I'm Head of Commissioning here at the CCG. I support the out of hospital care agenda, so mainly supporting community services, and I'm going to provide this presentation on behalf of the whole organisation today. Is it okay to move on to the next slide, please? Thank you. So just to say thank you for inviting us along today, just to provide our high-level overview of our health response to tackling health inequalities across the Tees Valley. We have shared a more detailed paper that you've hopefully all had a chance to review, and we thought it would be useful to pull out the key points in these few presentation slides. So there should be around 13 slides altogether. The paper and the slides focus on our CCG plans, but we thought it was important to note at this stage that really to achieve the best outcomes, a partnership approach is preferable. And so as such, we tried to work really closely with Mark and others in his team to agree shared areas of focus and shared plans. And I think it was also just important to note at this stage that we're currently reviewing the planning guidance that's recently been issued nationally, and we are working on a refresh of our priority areas and plans for this next financial year coming up. So some of the detail may change slightly over the coming months. I just wanted to make members aware of that, just given the time of year that we're at. Can we move on to the next slide, please? So I won't go into too much detail on this particular slide because I'm sure you're all already well versed on health inequalities, but just really to set the scene for the presentation, we felt it was pertinent to clarify that we are talking about unfair and unavoidable differences in mental and physical health between groups of people, which can arise due to a number of factors, including where people are born or where they live, and these inequalities can impact their opportunities to achieve good health and good well-being. Could we move on to the next slide, please? Thank you. And really similar to the last slide, I'm sure everybody is already well aware of the current health inequalities across the Tees Valley. But just again to set the scene and just to highlight that the health of our population is generally worse than the England average, and this is multifactorial, with high rates of obesity, smoking, GCSE attainment being lower than the national average, along with physical activity being lower than the England average. There's obviously, a lot more data on this and much more detail, but I've just included this snapshot just really for context and set the scene for the rest of the presentation. Can we go on to the next slide, please? Thank you. Obviously, we're acutely aware of the inequalities present in our region, and I guess we're not alone in that concern about rising rates of health inequalities. And nationally, there's a mandate to focus on 5 priority areas with the aim of really tackling health inequalities. I've listed them in the slide, and they include focus areas such as service restoration, mitigating against digital exclusion, accelerating preventative programmes to strengthen health outcomes, and strengthening leadership and accountability. And there's also a national driver, which is coined the Core 20+5 approach, which is the image in the slide, which is really designed to support systems and partnerships to focus on the most deprived parts of our populations and 5 key clinical areas for those populations, which include maternity, respiratory disease, early cancer diagnosis, hypertension, and severe mental illness. Could we go on to the next slide, please? So really, in order to respond to these nationally mandated areas of focus, plus recognising and improving our local health outcomes, we have collaboratively developed plans. We've tried to work really closely with our system partners, such as local authorities and our Directors of Public Health, to develop and sign off proposed plans, and also to ensure alignment with health and wellbeing priorities across each locality area. We are also a partner of the North Eastern Cumbria Health Inequalities Advisory Group, and this group's been pulled together across the region really to ensure that we learn from all of our system partners across the area, and to hopefully enable us to share areas of best practice. In order to provide the summary in the paper shared in the presentation today, we've tried to extract from our detailed plans the actions that really align to the national context I shared on the slide previously, and how we want to really try and tackle health inequalities. And I've proposed in the next couple of slides to go through each of them in turn, so it hopefully gives you a flavour of the detail that we've got that supports delivery of these key areas really. So the first one, is around restoration of NHS services. There's a whole range of detailed plans that sit within this particular section, and there's lots of actions that are focused around improving data capture and recording of vulnerability indicators, so we can really better understand who presents for healthcare and when, and so we can target support for those that need it, especially when we're thinking about restoring access to services. There's also work around developing specific toolkits to really help all partners take a more intelligent review of patients and the public who may be waiting for treatment, to offer better support on an interim basis where that's needed. And there's also a whole raft of plans which you might already be aware of that aim to restore access to elective services, increasing capacity in general across the system, and also to support restoration of other community services that were affected because of COVID, and to make sure that we take a place-based approach to this restoration. So as well as bringing services back online where that's the right thing to do, taking into consideration the best place and the best model of care for those particular services. Can we go on to the next slide, please? The next priority area is focused around mitigating digital exclusion, and I would hope that during COVID we were all aware of the advances made in our use of technology to keep us connected, and the actions around this specific area aim to ensure that we try and mitigate against digital exclusion and any exclusion that's been created as a result of the pace of change that we've gone through recently. We really need to evaluate the changes that have taken place through a health inequalities lens, and to make sure that we can address any detrimental outcomes, which is a key focus area. The CCG is also a partner of an emerging digital exclusion plan and strategy. It's been developed in partnership with our local authorities, Health Watch, and other voluntary organisations and networks, to make sure that we can work collaboratively and align our outcomes where that's the right thing to do. And just, I guess, to flag in this particular slide, but across the system where we are looking to transform, we're trying to do so in a co-designed way with key partners to really learn from our experiences and implement things that have worked really well. We don't want to lose sight of the positive impact of that virtual access has had, because for some patients and some groups it's been really important, and they've really welcomed some of those changes. So we do recognise its role in health pathways, but we want to make sure that we take it into consideration when patients discuss what matters to them. So really take it into consideration as a part of a range of options when we think about how we can make care personalised for patients in the future. Can we go on to the next slide, please? Thank you. So there's a big focus nationally around making sure data is up to date and accurate, so we can really be assured that we understand the needs of our patients and their associated vulnerabilities, and so we can provide targeted personalised care where we need to. And there are a range of detailed plans which focus on improving the coding and recording of activity across primary care, developing dashboards to support support partners to really see the health inequalities of our population, and so we can implement actions to address any concerns, plus working really closely with our key system partners such as our local authorities to link relevant data sets where we can to really improve our intelligence and then hopefully therefore improve the actions and outcomes that we get as a result. We'll go on to the next slide, please. This one spans 2 slides, apologies, because there was too much to put in one. But just in relation to accelerating preventative programmes to really proactively engage those at risk of poorer health outcomes, there are a whole wide range of plans in place to try and address this. It does include focus areas such as evaluation of the COVID vaccination programme, to really try and learn about the effectiveness of such a large rollout programme and hopefully try and apply the best aspects across other areas. Work's also focused on targeting underrepresented groups across a range of long-term conditions and health concerns such as cancer to support people to present earlier. And we're lucky but really fortunate as the Tees Valley at being a pilot site for the targeted lung health check programme. So it's currently being mobilised and rolled out, which should make a real impact on the numbers of people that are caught early with lung cancer who can be effectively treated. And work's also being built upon to further roll out successful support services such as social prescribers, care coordinators and health coaches in primary care to really support our most vulnerable groups and offer increased help and support to navigate the health system and access care where needed. And on the next slide, there are some further plans which try to summarise some large-scale complex programmes of work that are focused on improving outcomes across respiratory, CVD and diabetes programmes, plus campaigns to improve preventative programmes, all with plans being developed and actions being reviewed through a really specific health inequalities lens. Just go on to the next slide, please, if that's okay. I've pulled this particular action out. It does link to the last 2 slides, but I felt that it warranted a little bit more detail being shared. So it relates to accelerating preventative programmes and tackling health inequalities at a neighbourhood level, and it's linked to an enhanced scheme primary care networks have signed up to locally. So it's all focused around working as a system to identify a population experiencing inequality and develop plans to address this particular unmet need. So our PCNs across Middlesbrough are really well engaged and are working really collaboratively and really closely with the local authority and with Mark and his team. As a collective group, they've agreed that they feel the underlying factor to most inequalities in the area is poverty. So they're developing plans focused around this, around 3 key health themes, which is mental health, alcohol and frequent attenders of primary care. It's very, very much a locally developed programme, but it should complement the range of other actions shared in the presentation slides to hopefully really use this opportunity to build from the ground up and make a real difference. And as we're working collaboratively and supporting the PCNs, there's a chance to build on what we have and really take a targeted approach where that's the right thing to do. So just to try and conclude, and I'm conscious I've shared a lot of information in a few short slides, these are our plans as they stand at a really high level, just to hopefully give you a flavour of the complex and diverse programmes of work that we've got in place to really try and tackle health inequalities across the Tees Valley. The slides are a snapshot and there's a lot of detail that sits behind these. And I think it's just, again, important to reiterate that we've developed our plans in collaboration and we do need to deliver these in collaboration to really achieve the best outcomes. So I just felt like it was a good opportunity to share how grateful we are to our local authority and our DPH colleagues for working so closely with us on this agenda on a continued basis. As I said at the beginning, we do need to undertake a refresh because of national planning guidance being issued, but we don't expect the areas of focus that I've shared in the presentation to change significantly. It might just be some detailed actions within that need tweaking depending on potential timescales or changes in the guidance. So we will continue to work through our plans that we've set out, continue to monitor, continue to evaluate and learn from these programmes of work and hopefully apply any learning to future projects that we may agree to undertake or to start up in the next financial year and years after. So that's the end of the slide deck, and hopefully it's given you an overview of where we are to date, and hopefully this particular presentation and the next one will give you more of a holistic view of our approach to tackling health inequalities.
Thank you for that, Katie. Most informative. I must admit it took me some time to read through your report, but it was very
Apologies, it was
informative.
quite detailed.
Yes, it was. Yes. I see I've got two hands up to ask you some questions. Are you prepared to take them? Yes.
Yes, absolutely.
Yes.
Yeah, thank you.
Councillor Halawi.
Thank you, Chair. Thanks for that, really. Yes, it was very informative. And two words I picked up right from the beginning, which I think are key. You said that these are unfair and, unavoidable, but I think we've got some real serious concerns within that aspect there. Apart from that, my other concern is, have we got a notional amount of money that would need to be spent in order to reduce these health inequalities? I mean, if we were to go for enough, it were to be really much fairer, and therefore we could avoid a lot of the problems that we have. How much money would need to be put on that? And if we were to go for a halfway house, what could we manage with to even get to some sort of level playing field with other areas of the country? So it's the financial aspects that are really of concern, because I take on board all that you say, Katie, and I appreciate all the health inequalities that we've discussed for many a meeting now. And I think we're really aware of the issues behind the inequalities. But it's the finance that, it seems to me, is also key, as well as all the collaborative working and all the rest of the ideas you suggested.
I think I agree. I think it's a really important point, and we are aware that ourselves and our partners don't have an endless pot of funds to invest as much as we would love to. We have had a conversation through the Health Inequalities Advisory Group across the North East, and we've all collectively flagged our concerns around our ability to respond to the need that we have across our areas, and we're trying to do as much as we can collectively to highlight the need across the Tees Valley and to try and make sure that we receive and that we are in an opportunity to receive as much support as is possible. I'm not a finance expert, so I wouldn't like to share too much detail because it would be unfair of me to do so, but I do know that as an organisation, we will align the budget that's made available to us and do as much as we can to make sure that we do tackle health inequalities. And we've made it really clear that across all of our projects, all of our plans, whatever we do, we need to take a health inequalities lens. So if there's an opportunity to make a difference, however small scale, within the budget that we have, we will absolutely do so. If there are some specific financial questions that you have, it might be worth us asking our finance director, Mark Pickering, to attend a future meeting to give a more detailed overview. But hopefully that gives you some assurance that we are doing as much as possible within our realm to make sure that we align the budget that we have to make a difference. Apologies, I think you're on mute unless my sound's gone funny.
No, you're right, Katie.
Oh, sorry.
Chair, could I just come back and respond to Katie's point?
Yeah, I've got quite a few people waiting.
Yes, and I'll just say quickly, I'd personally be very interested in a financial overview of some of the particular aspects that you brought up as the health inequality actions. I think my bottom line on finance would be, we just haven't got enough, and the likelihood is that we won't be given enough. And I think we probably all agree on that without a precise figure. But I think that's the key point, isn't it? We haven't got enough money to tackle the problems that we have, and we need a considerable amount more money in order to make the differences that we would hope to make. And yes, I would like more financial information. If you agree, Chair, and the panel agrees, that I'd be interested in that personally. Thank you. Thank you,
we'll
Chair.
discuss that, Councillor.
Okay. Thank you.
Councillor Marsden.
Yes, thanks, Chair. I agree with Alma. Key to this whole thing is resources. If you don't have the resources, it fails. A comment really, looking at the figures, they could have been from years ago in Middlesbrough. The numbers and the problems are not new. What's happened to the previous plans, and how? I'd rather be sounding more positive, but this is Middlesbrough from years ago. It might be difficult to answer, but how confident are you that this planned action you have can make a difference? Bear in mind, we have to get the residents, the public on board as well, that want to be helped. Thanks, Chair.
Thank you.
I mean, I agree. It has to be a partnership approach, and it isn't something that we can do in isolation. We see the best outcomes by working together, and by taking an approach that spans communities, place-based, as well as some more regional conversations. As an individual, I'm confident that we will do our best, and that we will take the best approaches that we can as a CCG, and we've hopefully demonstrated in some of the slides that we're trying to make sure that we get our partners on board and that we work together. I think some of the opportunities that we've got at a primary care level are brand new, which is really exciting. And it's been really, really positive that all of our practices are really well engaged, as well as the DPH and his team. So I would hope that we can share as much assurance as we can that we want to work it, want to go in the right direction. Sorry, I'm just going to shut the blinds because I don't think you can see me very well. I won't be a second. Is that better? Sorry.
Okay. Does that answer your question, Councillor Mawson?
Yes, thanks, Chair. I think just briefly, partnership working is possibly what hasn't happened in the past, and hope works this time. Thank you.
Councillor Arundel?
Thanks, Chair. Yeah, money isn't always the end of everything. I think what needs to happen is, and I doubt if we'll ever achieve it, is a cultural change in certain people's lifestyles, and the fact that they accept responsibility for their own health and want to be healthy. Until that happens, you can do whatever you want. If people are determined they're going to smoke and whatever, and drink too much and all the rest of it, you're just wasting your time. Until they want to be healthy, you're never going to do anything about it. And it's not because, yes, I agree that money plays a part in it and their income plays a part in it. But if they can afford to smoke and what have you, obviously they're not short of money. That's my view anyway. They've got to accept some responsibility. Help them by all means, but they've got to come on board as well. Thank you, Chair.
Thank you, Councillor. Have you anything you want to add to that? Katie? Kate?
There are some roles that I shared in the presentation that are brand new that we've never had before across the Tees Valley. So things like social prescribers, health coaches and care coordinators. And I completely agree, individuals do need to take, they need to want to make a change, but I think there is more support than we've ever had before to really help individuals navigate the health system and access as much support, wraparound support services as possible, and to hopefully have some of those really meaningful conversations around what matters to them as an individual to really try and make a difference. But we will continue to do as much as we can.
Thank you. Councillor Rooney?
Thanks, Chair. Thanks, Katie. That was a really comprehensive report that was sent out, which we've only just, excuse me. So what's happening? Sorry, I apologise for that. And it was a lot of information to take on, so I'd like to make a request that this is brought back at regular intervals so we can see the progress and maybe have some opportunities to question things. I have actually 3 questions. One is very simple. It's who is the health inequalities lead that is referred to within the report? I think it's on page 20. I'd like to know what is being done and what is new, which kind of fits in with what Councillor Marston was saying. And just yesterday, the Office for National Statistics has just put out an avoidable mortality report in Great Britain, and that fits in with the information that we've got in this report. But it says that in Middlesbrough, it has the highest female preventable mortality rate. That's horrendous. I really don't want to be at the top of that league. And on International Women's Day, I'd like us to be able to focus on this. Obviously not at this meeting because there'll be more information to be brought to it, but I'd like to know, what factors influence that, what factors are influencing those figures. and examine what actions can be taken, because they are reflected in your report, but these are just more up-to-date statistics. Thank you.
The Health Inequalities lead across the primary care networks, they've all agreed to work collaboratively, and they've appointed Lisa Jones, who works at the local authority, to be a shared Health Inequalities lead, which I think is a really good symbol of true partnership working and wanting to work in collaboration. And hopefully each of those primary care networks can develop some shared principles and some shared ways of working, but also have an opportunity to focus on their individual populations to really try and address what matters to those. I'm more than happy to bring updates back into the future, and we could maybe either share a general update, or if there's some, we could maybe do some deep dives into some of the specific schemes, which might be allow us more time to focus on what we've done and where we're going. I think with anything like this, we don't always see change overnight, so it'll be difficult to demonstrate in the numbers per se, but there's a whole range of factors that we want to try and monitor and address from an outcomes perspective. So there should be information that we can share that reflects where we've got to, potential challenges along the way, but also opportunities for best practice. I haven't specifically seen the last report that you've mentioned, but we're in regular contact with Mark and his team, so I'm sure it's something that we can look at. And if there needs to be a specific response in this group, we can bring it, or we can give some assurances about where it is being discussed and where it will be reflected upon.
Yeah,
Thank you.
Thanks for that. I mean, that does, go some way to reassuring me, but I would just like, through the chair, to make a specific plea that we look in detail at the inequality around women and why women are dying younger in Middlesbrough than any other place in the country. I'd like us to examine that and hopefully get us shifted down the table eventually. Thank you.
Thank you for that, Councillor Rooney. I've got a hand up, and I think it could be Karen Hawkins. Is that correct?
It is, Chair, yes, thank you.
Would you like to introduce yourself, Karen, please?
Yeah, I'm Karen Hawkins. I'm the Director of Commissioning for Primary and Community Care. I've met you all before, and it was upon my request I asked that we bring a further presentation to this meeting in relation to health inequalities, as you'll be mindful that the local medical committee did provide a presentation, but that was through the lens of GPs only and through a primary care perspective. So we wanted you to have an overview across the whole of health in terms of what we were doing from a commissioning perspective around health inequalities. And Katie works in my team and as brilliantly presented today in terms of giving what is a really complex subject, some high level overview for you as committee members. And I would just like to reassure you as a committee in terms of some of the queries that were raised in relation to funding, but also in relation to some of the work that's been undertaken. As you'll appreciate, every organisation has an allocation in which we have to work within. That spreads from health and local authority perspectives. And within those allocations, we do have an element that recognises our health inequalities within our area. However, what I wanted to reassure the committee of is whenever we're planning for healthcare services or reviewing healthcare services, we do that through the lens of health inequality, and we ensure that we have a specific focus on that. I think the work that we're doing in collaboration can't be underestimated, and certainly I think if we were to bring something back in the future, I think what we should do is do a collaborative approach to that with our public health colleagues so that we're not duplicating some of the work, because we work very closely. And you'll also appreciate a number of the factors that influence health inequalities sits across society, the community, individual families and individuals themselves in relation to some of their lifestyle choices, some of their physical health and their relationships, as Councillor Arundel pointed out earlier, around that self-care that needs to be undertaken as well. And certainly from a health perspective, although we do have certain requirements around planning, we don't do that in isolation, and we absolutely do it through that lens of health inequality. So very happy to come back at a future meeting and provide what I think should be a joint presentation in relation to the work we're doing. And it's really exciting, the work, and it was I alluded to it previously, the work that was happening within the primary care networks across Middlesbrough. And as you know, we've got 3 primary care networks weeks, working across all of the practices in Middlesbrough, and for them all to agree on a focused area in relation to not only health inequalities, but population health, and an approach to population health management through the lens of poverty with a specific focus on mental health. And that picks up a number of those factors that we've discussed today. So would be really pleased, not only for ourselves to come back and present, but certainly some of the clinicians involved in that work as we move that forward in Middlesbrough. It is at the start of the programme of work. And I think what has changed, and I think one of the councillors alluded to it earlier before, is there is really a partnership approach to this now. There isn't the organisational boundaries that have been in place historically. We've absolutely working together to try and address this for the people of Middlesbrough. So it was just to offer you some of that reassurance, Chair. Thank you.
Thank you for that, Karen. Is there anybody else before I ask a couple of questions? No. I wanted to talk to you with regards to the social prescribing issue, because it is quite new and it affects everybody and every way. How is this working within the area? I know it hasn't been running that long, but is it working for all these issues that our people have?
It is quite new, like you say, but we do have good uptake across all of our primary care networks. So they've all got some social prescribing support in place. Plus, some also have some other roles, such as care coordinators and health and wellbeing coaches, to really try and holistically complement that clinical care. Some of our primary care networks that have taken a specific view on certain pathways, and we've recently asked them to pull together a little bit of a self-assessment to reflect on how it's going, how, you know, what they've learned so far, how it's working, and we're just working through that feedback with them at this moment in time to try and offer some enhanced support in the future. We've also agreed with NHS England to invest some money into some training for those roles, so we can continually support them to engage in training, to improve their tools and use of tools and techniques in the future to really try and bring the best outcomes to patients. But the feedback so far has been really positive, and they do seem to have made a real difference. And there's an opportunity to, in the future, to allow not just referrals from primary care clinicians to social prescribers, but to allow referrals from our other partner organisations. So if a patient's maybe being supported in a community or an acute setting with a respiratory condition, and they've highlighted that that patient has a particular need or there's a concern, they can then also refer into that social prescribing support to really offer as many touch points as possible.
Right, thank you for that. Is there anybody else have any other questions? Councillor Morstan?
Yes. Thanks, Chair. Just one quick, is there a time target for your actions, the results?
So with most years, we're always asked to put annual plans in place, but what a lot of the work that I've shared in the presentation today is work that we're trying to build upon from previous years, and just using all the opportunities available to us to really drive forward transformational change. So there will be some notional metrics and targets for the next financial year, but really for us it's that longer term vision, because you can't change individuals' behaviours overnight. We're in it for the long game, really. So we're trying to just make sure that we utilise all the opportunities available to us to make some differences. But we won't see it overnight. It will take a little bit longer. But I think the fact that we've agreed as partners to work on a shared agenda and to work collaboratively, like you say, it is a little bit new, but it's really exciting, and hopefully we'll try and enhance that pace of change as quickly as we can.
Thanks, Katie. We wish you every success. Thanks, Chair.
Thank you.
Thank you for that. Is there anybody else who'd like to ask anything or make a comment? No? Right. Karen, did you want to add anything else?
No, thank you, Chair. Katie covered everything.
Right, thank you both Katie and Karen for that. I'm very sure after our discussion today, we will be calling you back to talk to us about different angles, as suggested by the councillors. Can we move on now? And thank you both very much. If you would like to stay to the rest of the meeting, you're very welcome to do so, but I do believe you will be very, very busy. Thank you. Can we move on now to health equalities, public health perspective. We have Rebecca Scott from Public Health with us today to provide us with health inequalities information in the public health perspective. Would you like to start now for us, please, Rebecca?
Great, thank you, Chair. Yeah, thank you for asking us to come along today. And I think really this presentation follows on really nicely from the presentation that Katie's given. I think there is some slight duplication at times that I'll skip past, including the PCN work, but I think it just shows that partnership working, that we are working together and we are working on the same page. So I will just attempt to share my screen. Can everybody see that? Can people
Yes,
see the
thank
screen?
you.
Okay, great. Okay, so I'm just going to give you a bit of an update from a public health perspective. Oh, it's stopped sharing.
It's gone totally, Rebecca.
Hmm?
Oh, say back again, thank you.
Is that back again? Okay.
Yeah.
Okay, so this was the ask that we had from the panel. So it was to understand what public health initiatives that we have regarding reducing health inequalities, and is there any measures around that? And also around our views whether the current challenges faced are solvable, or is it a case of managing rather than improving? So really, I just kind of wanted us to start when I was thinking about the presentation, it was just around kind of looking at reframing it slightly around the first question around how we tackle health inequalities. And I think, this covers kind of things that Katie was saying was, they won't be solved by initiatives alone, but do require action across the civic, community and service dimensions. So I've just put here the population intervention triangle, which is an approach that we are using in public health and across other partners when we consider initiatives, thinking about things, civic interventions such as policy and strategy development, legislation, economic development that have the potential to have a large impact on a large number of people. Also thinking about effective services and service-based interventions that we have, and how we utilize our community and our community assets as well. So I'm sure you'll all be aware, the Marmot Review into Health Inequalities in England was published in February 2010 and then updated, and it proposed evidence-based strategy to addressing the social determinants of health, the conditions which people are born and live, work and age in, which can lead to the growth of health inequalities. So the document set out a framework for local action under two policy goals: to create and enable enabling society that maximises individuals and community potential, and to assure social justice, health and sustainability are at the heart of all policies. So central to this was the recognition that disadvantage starts before birth and accumulates throughout the life. And this was reflected in Marmot's recommendations, so 6 recommendations, which started with the priority, the best start in life, and then covered the other recommendations. So again, I'm not going to kind of dwell too much on this, but what are health inequalities? And like Katie said, there are just unavoidable differences in people's health across the population and across different population groups, that are overlapping. I think the health inequalities are driven by complex interaction between many factors, and a lot of these have been exacerbated by COVID-19. We know that kind of the biggest impact of COVID-19 was felt on our most disadvantaged communities, kind of exacerbating their existing chronic and social conditions. Again, I'm not going to dwell too much on this because I know that it has been covered and it has been discussed in the questions, but looking at the scale of our challenge, so looking at the difference in life expectancy between Middlesbrough and England, and looking at the inequalities in life expectancy as well. So not just the difference in expectancy, but the actual, inequalities. And again, they begin from birth. So just to recap on kind of this place-based action, so looking across the civic, the community and the service level. So public health approaches, so looking at a civic level, you know, we'd like to achieve an embed a health in our policies approach. So a collaborative, working with all our key partners. So building, you know, wider consideration of health issues into wider policies to create win-win solutions that impact on multiple policy goals. At the moment, we're looking at a way to do this is we're currently piloting the health inequalities impact assessment across 5 key areas in the local authority. So the health inequalities impact assessment is a tool. So it helps, it's a pragmatic tool for organisations, supporting them to consider if they've harnessed all the opportunities to address health inequality. And the tool that we use, it uses the 6 Marmot recommendations as well to focus the work. Again, I've put in here, following on from Katie's, that the work with the PCNs that we're doing, looking at the initial focus on poverty and health inequalities at a population level, and looking at mental health as well. So community-based approaches, the COVID-19 vaccination rollout has made it clear for more, you know, we need more resilient systems supporting immunisation at a community level. And I think, you know, this has been done really well at a community level with the COVID vaccinations in partnership with PCNs and other colleagues across the local authority and, you know, regionally. So we've utilised local data to highlight areas and cohorts of low uptake. It developed a network of community champions, which I think that Katrina did come and talk about the community champions. Developed capacity and skills within these champions, and you know, they're trusted voices within our communities. Addressed the accessibility via the mobile pop-up clinics, and this was a collaborative approach. And we worked with a behavioural insights company to develop targeted messages, so it wasn't just one message fits all. You know, we worked with, you know, what messages for different cohorts and different communities, and I think that is something, well, it is something that we will carry forward as well. So another example of a strong community approach is the Changing Futures programme. So the ultimate aim of this is to improve the outcome for adults experiencing multiple disadvantage from substance misuse, mental health, domestic abuse and homelessness, and contact with the criminal justice system. The programme aims to do so by ensuring a coordinated approach from local organisations, addressing the needs of the whole person rather than several different organisations working on separate issues in a silo. So a large majority of the key workers in the programme have lived experience in one or more areas, and it also aims to build capacity of our VCS organisation as well. So service-based interventions, so public health, along with lots of our partners, invest in prevention, preventative services that address some of the biggest causes of health inequalities in Middlesbrough, such as substance misuse, alcohol, smoking, best start in life, obesity, sexual health. But like mentioned in a previous slide, probably what we don't want is these services just to work in silo. When we're looking at the services, it is with this health inequalities lens that's been mentioned before. So it's looking at located services in hard to reach areas, providing outreach to support more complex service users, using those behavioural insights approaches to inform the marketing and communication of services, making sure it's free at the point of access and people know that it's free at the point of access, so that's not a barrier. Also looking at, you know, access in terms of transport and how people get there, creating routes to work through public health staffing models, lived experience, apprenticeships, 50 Futures, and developing the skills of our workforce to better support vulnerabilities, looking at things like our trauma-informed approach. So health inequality is solvable, and I think this has been kind of one of the questions. So the preventable differences in health status across the population. So they are solvable or can be reduced with political and societal will, going back again to that real need of working across that population intervention triangle. I've read lots of good papers with kind of evidence where this has worked. I can send out the link actually to a particular one with the minutes. So it does state that the 3 common levelling mechanisms whereby social gradients in health can be reduced at scale. So improving social and economic conditions, increasing healthcare access, and through policy and legislation as well. So again, working around that population intervention triangle. So levelling up population health through reducing health inequalities requires long-term action, that macro level policies and that target of social determinants of health. So I'll just stop sharing there. So again, it is all around that partnership working and working across that population health triangle. A lot of the interventions that we spoke about today, so the health and all policies, the changing futures and the PCN work, you know, it is within its infancy, some of it, but again, would be more than happy to come back at a later stage and present some updates on this.
Thank you for that, Rebecca. Yes, an update would be good. Thank you. Can we? Yes, Councillor Rooney, can I take you first?
Thanks, Chair. Thanks, Rebecca. That was very quick. And
Sorry.
we have seen some of it at another scrutiny, but not all of us have seen it. So you know, it's building on things that we're beginning to understand a bit more. I'd like to see this come back and again be broken down, so we've got an opportunity to digest a lot of this information. So things like your 5 identified areas that were on slide 10, which you just went past, and I'm not sure whether you actually told us them or not, because I didn't catch the link. And the whole person approach, it's not new, it's needed, absolutely, and that's what we should be doing, but we've tried it in other sectors, particularly around housing and homelessness, and putting services around people rather than just, you know, direct them at them. So it'd be quite interesting to see how that develops and what the projects and the work actually looks like. So I very much welcome you bringing that back and then giving us an opportunity to, you know, to digest the information as we're going through. But thank you.
Definitely, and I will circulate the slides so you can have a look in more detail. I just didn't want to kind of go through point for point, but I guess in terms of the health inequalities impact assessment, that's a whole presentation on that alone and kind of the prompts that we use. So again, if anything is useful, I'm more than happy to share or talk people through that process.
Yes, thank you for that. It would be good if you could actually share your presentation with us, and we'll look very closely at it and see what we can pull from it, as Councillor Rooney's just said. Councillor Halawi, you're on mute, Councillor Halawi.
Sorry, at risk of repeating myself, Becky, and thank you for that very interesting PowerPoint. I would appreciate looking at it closely and more slowly. If you send it to us, that'd be good. But, you know, one of the 3 sine qua non factors in all of the inequality debate are, as you said, you know, the political will, which means the social and economic conditions in which we find ourselves, as well as access to services, policy and legislation. I just don't really know if the political will is there to invest in the social and economic condition that would make things improve. And I know that's not the only determinant, but it is key. So again, I'm back onto the financial issues and how much we get and is it enough and how far can we work with all our partnerships. If we don't have the social and economic will from a political angle to improve things, then I think we are up against it. My other question is a bit, again, in repetition, but it's when thinking about what Councillor Rooney said earlier about the new information from the Office of National Statistics about in Middlesbrough, we have the highest preventative mortality in women. When we're faced with information like that, which comes out on a fresh basis, do we have an answer to that? Do we have a media release? Do we have a press release? So if somebody meets me today and say, oh, Alma, you know, somebody just said we have the highest, what do you think about that? What are we doing about it locally? How is Middlesbrough addressing this? What are we doing within our community? What do I answer specifically to any new emerging issues? Because quite frankly, right now, I don't know that I could say to anybody exactly what we're doing to deal with that precise point or any others of that nature that come along. We get all these statistics all the time and we're always at the wrong end of the league, or often at the wrong end of the league. And you know, sometimes you just don't know how we can respond to them. We haven't got that information.
So in terms of the first point around the finances, I think, you know, this is really around that partnership working and looking at what resources that we have as a partnership working, because, you know, there's always a finite of a resource around. So I think it is around that partnership working. In terms of the report, I haven't seen it yet, but I will be, it's noted for myself to look at today. And I think it is more around that investigation as to why, to looking at, you know, what is causing that locally. You know, we do have lots of interventions, lots of services available, but I think we need to understand it more before we can comment on it. But again, I'm happy to take that away and look into it.
Yes, thanks, Chair. I would appreciate that. I think my bottom line is all this partnership working. We just need more finances, and I will put a plea in for this panel to do whatever we can to request whoever it may be, governmental level or whatever. We need more resources, financial resources in this area to address our massive health inequality issues. And, you know, partnership working and everything's all fine, but we still need more money, it seems to me. We can't get away from it. Thank you,
that's
Chair.
something we will definitely look at, Councillor Alawi. Councillor Arundel?
I got it. Thanks, Chair. Yeah, just comment on Councillor Alawi's comment on why the situation is what it is in Middlesbrough with female mortality rates. I know a couple of years ago, Middlesbrough, women in Middlesbrough are the highest health-related issues due to alcohol in the whole of the country. So that might be one of the reasons that we've got this situation. And also in licensing, we have saturation areas where we don't allow or try to prevent any more outlets of alcohol opening up. And they all fall within deprived areas. So what does that say? It can't be about money, can it? I mean, it's a lifestyle, it's a choice. I mean, nobody forces them to, you know, to drink wine. Don't get a bottle and shove it down their neck and force them to drink it. They choose to drink it. And the consequences of it are, they have a bad health issue. So I think I'm always going to say that, you know, people have got to start taking some responsibility for themselves. Yes, by all means, help people, but they've got to help us to help them. Thank you, Chair.
Thank you, Councillor Arundel. Did you want to add anything, Rebecca?
I think it's around looking at those root causes. So, you know, as to those lifestyle choices, looking at those root causes and looking at what's leading it to that. And I think that's what we're trying to do with a lot of our work now is understanding that and listening to our communities.
Thank you. Councillor Alawi, did you want to come in again? You're on mute again, Councillor.
Sorry, I'm busy putting the hand off and forgetting to unmute. I agree with what Rebecca just said. Then I think it's a very big picture, Councillor Arundel, and I think we need a lot more understanding of the issues in people's lifestyles, as Rebecca just said. And I think together with that, we need a healthy dose of compassion. Thank you.
Thank you. Does anybody else want to add anything? No? Right, thank you. Rebecca, we may be calling you back as well for some information. So we will let you know as soon as possible. And if you send everybody a copy of your presentation, much appreciated. Or if you send it to Scott, he'll send it to us all. Thank you. Right, can we continue? And we'll go to agenda item number 6, which is the COVID-19 update. And I do believe, Rebecca, that you're going to do this today.
I am. I'm just going to give a verbal update and I will talk slower. So give a verbal update on that. So looking at kind of the national board. So all of Teesside areas are looking quite low. Middlesbrough is now 133 out of 149 local authorities. We're averaging around 30 cases a day, with a rate of 210 per 100,000, which has leveled, and we're looking at stable. We've been in the 200 mark for a few days now, so it's looking at stable. In terms of hospital admissions, so we've seen these drop quite dramatically since January, and now they're looking more stable around the 100 mark. And these are admissions with COVID and those that are in hospital diagnosed with COVID. COVID cases in critical care have reduced and into very low numbers. In terms of our vaccinations, we're on 77% for dose 1, 71% for dose 2, and boosters of 53%. That's compared with the England average of 80% for dose 1 against the 77% in Middlesbrough, 75% England for dose 2 against our 71% in Middlesbrough, and 59% in England for the booster against our 53% in Middlesbrough for our booster programme.
Thank you. Thank you. Is there anybody who would like to ask a question before I make a comment? Yes, Councillor Rooney.
Thanks, Chair. In terms of the vaccination programme, are we still doing the outreach vaccination services? So we've still got the buffers and the mobile units and things?
Yes, we are.
Right, thank you.
Councillor Arundel?
Yes, thank you. What are the lowest take-up areas, wards, with vaccination in the town?
I will have to get back to you with that, but I can send that out with the minutes.
Yes, please, if you would. Is that okay, Councillor?
We do have that information, so I can send it out to the minutes. I just don't have it in front of me right now.
Right, thank you very much. Can I just ask a question? I know the government are possibly bringing in that people are going to get a 4th dose of the vaccine for the vulnerable and over 75s. Do we know anything about this yet?
Again, I will get Lindsay to update on that and I'll send that out with the minutes.
Okay, thank you very much. Yes, Councillor Rooney?
Yeah, thanks. Just a side issue really, Rebecca, and I'm not sure whether you'll be able to answer it, but in terms of the lateral flow tests that they now have to be paid for, do you know what we're doing within our services where are we still asking people to test twice a week? Are there some areas of service delivery that we're still doing that, and are we helping people in terms of providing the tests for them?
I think that, again, I'll look into that with Jackie, who's picking up the testing. But with the tests, obviously that they're supplied by the Department for Health and Social Care, and Karen has her hand up, so she might.
Yes, I'll bring Karen in now. Karen?
Sorry, mine wasn't in relation to testing, it was in relation to your query around the vaccination programme and the continuation. So there has been an announcement around 3 elements of the vaccination programme as we move forward. So there is going to be continued access to the COVID-19 vaccination to all children over 5 to 11 years, and a vaccination offer of a spring dose at around 6 months after the last vaccine dose for those that are over 75, and any residents in care homes and older adults, and any immunosuppressed children as well. So you're right, Councillor, in terms of there is an expectation of a 4th dose in the spring dose. And there will also be the continuation of the vaccination offer to those that have recently become eligible. And that continued engagement to improve the confidence and continue to promote the uptake of the vaccination programme. And then there is expected also to be delivery of an autumn COVID-19 vaccination programme, but those details are yet to be announced in relation to the guidance that will be issued for that. And then we're also being asked to plan and put contingency plans in place to rapidly increase capacity should there be an announcement like there was previously through the last COVID and surge. So we're asked to be putting plans in place and working with system partners to ensure that we've got plans on the shelf to take off should we need to for everybody over 12 years of age. So that work is currently being done through the vaccination programme, and that's a multi-agency approach. So it was just to make sure that we answered your question in relation to that.
Thanks, you for that, Karen. Does anybody have any more questions for Karen or Rebecca? No, thank you very much. Can I just say that everything we've mentioned today, looking at finance, etc., we will look into this and ask Karen or Rebecca or Katie to come back and give us that information as the councillors have asked. Can I move on now to agenda item number 7, which is the Chair's OSB update. The OSB met on the 22nd of February. The Executive Forward Work Programme was discussed, an update regarding the attendance of executive members at OSB, the Chief Executive's update Update from Scrutiny chairs. The position of the revenue and capital budget at Q3 21-22. The corporate performance update at Q3 21-22 were all discussed. Thank you. Is there any other business for today? Does anybody want to make any other comments? I would like to thank you all for your attendance today. It's been most informative, and I take on board everything councillors have got to say. Thank you very much.